Wonderful.
Good stuff. All right. Well, thank you very much, everyone, for joining. Sorry for the technical difficulties at the start. It's lovely to see you all. And I think I know all of you. I'm hoping that beeping is stopping now. But my name's Hannah. I'm an infectious diseases clinician, and I'm currently coming towards the end of the second year of my PhD, working with Peter, with Liz, and with Emily, and working with many of you as well on a project looking at heterogeneity and IGRA-based MTB immunoreactivity in urban Malawi. And the aim really for today is, as I say, we're sort of coming towards the end of the second year of the PhD and aiming to wrap up data collection by the end of this year. And at a stage now where we've got some results coming through and really wanted to share some work in progress with you all. And particularly a lot of you have given a lot of input into the sort of project at various stages, from the planning, bits of the execution. And so sharing where we're at the moment, and then really kind of maximising time for discussion, because it would be great to get your thoughts and feedback on what's coming up next. So yeah, as Liz says, the plan is I'll probably present for about 25 minutes and then leave plenty of space for discussion at the end. But if there's anything that's not clear, do just jump in the meantime. Just so you know, I can't, with the current precarious setup that we have, I can't see the chat. So maybe Peter, Liz, if there's anything urgent that comes up in the chat, if you can just give me a shout and I will address it there, and then otherwise we can discuss at the end. So I don't need to introduce to this audience, but we know that TB continues to be the biggest infectious disease killer in the world, and that while over recent decades we've been making progress towards NTB goals, we're not doing so at a pace that's fast enough to meet the WHO's targets. And actually over the last couple of years, a lot of that progress has actually been reversed by the COVID-19 pandemic. And the study, so I'm based here in Blantyre, and the Timasamala study that I'm going to be presenting is obviously based here. And one of the reasons that we wanted to work in Blantyre is it really sort of epitomises and illustrates a lot of the challenges faced by TB programmes as they work towards trying to end TB. So TB is an important public health priority in Malawi. It's the second most common cause of adult mortality, and overall it's responsible for around 1 in 15 deaths. So it's clearly a major problem. But we also see that there's a lot of heterogeneity in TB epidemiology, and the picture is not uniform. So we see that TB burden varies greatly within Malawi and indeed within Blantyre. So this is work from McHugh and Kundi, which shows that in 2019, neighbourhood level case notification rates show really wide variation from 0 to 144 per 100,000 adults. And this means that we need to get better at kind of targeting our efforts towards some of these hotspots. But we also know that case notifications don't tell the whole story. So in Blantyre, the ratio of prevalent to notified cases is around 4.5, meaning there's a really high burden of undiagnosed TB. And more broadly, we know that only around 60% of TB cases were notified to TB programmes globally. So we have a high burden of undiagnosed TB. And furthermore, the case notification rates are often systemically biased. So what we see in Blantyre is that case notifications are often lower in areas which are poorer, which have more men, and which are further from healthcare facilities. And so this reflects the fact that if we only measure people who actually make it as far as being diagnosed, we may just be missing those who are struggling with the poorest access to healthcare. And so recognising that case notifications don't truly reflect either the burden or distribution of disease, since 2007, the WHO has recommended TB disease prevalence surveys in countries with low case ascertainments as a way to kind of capture less biased cross-sectional data about TB burden. However, the problem with this in most settings, including in Blantyre, is that the actual point prevalence of TB is falling and is often very low. And this means that TB prevalence surveys often need to be extremely large and extremely resource intensive in order to generate granular data. And that was shown very clearly in a survey that was done in 2019 as part of the SCALE study, which has recently been published as a preprint, in which a prevalence survey was performed of over 13,000 participants in urban Blantyre and identified just 29 cases of microbiologically confirmed TB. And this means that, a huge number of people need to be screened in order to identify just a handful of participants. And really, this is unsustainably expensive and resource intensive, and it identifies too few cases to be able to draw any robust conclusions about high-risk groups or spatial areas. So the basis of this project is thinking about whether we can go a step earlier in the TB pathophysiological cascade, and instead of doing surveys based on, well, instead of measuring case notifications or doing surveys based on TB disease, we instead take a step further back and look at MTB infection or latent TB, which is often, I'm using MTB infection interchangeably with immunoreactivity, as in practice it's usually defined by positive results on tests such as IGRA or TST. And there are a few reasons why we might want to consider this as an option. So one is sort of epidemiological. So by taking a step earlier in the chain, we're getting closer to monitoring transmission, and we're looking at a sort of a metric of disease that's less likely to be impacted by cofactors which increase the rate of progression to disease. The second is that increasingly, as we're looking to eliminate TB, we need to be thinking more seriously about TB infection as a therapeutic target and considering whether there are options for prevention that we should be using more widely. And the third reason really is practical. So because latent TB is just so much more common than TB disease, practically that means that the sample size for studies can be much, much smaller in order to identify participants with MTB infection, and these are correspondingly cheaper.
Can I just quickly ask for a halt?
Okay.
And I just, if you don't mind, just going back to the previous slide. So we've now got, sorry, sneezing. We've now got Kazani, Dickens, and Yotam. So just in the interest of time, I think this is actually a great time to join. So I'm hoping, but if it's okay with you, we can leave introductions to the end, carry on the presentation. But basically, this I think is information that you're all very aware of. So Kazani, can I just quickly ask you to speak from your side just to confirm that? So you're aware of yeah, perfect, great. And then I think we're getting to results now. That's the interesting bit. Thank you. So carry on, please, Hannah. Thanks.
All right, so that's really the basis for the Timasamala study, which is a study looking at TB immunoreactivity for the purposes of surveillance in Malawi, and Timasamala is Chichewa for we care. And just to give everyone a bit of background to the study, so the rationale is that we're testing healthy children aged 1 to 5 in Blantyre for TB immunoreactivity, and we're doing that using IGRA. And there are a couple of reasons that we've chosen to focus on children aged 1 to 5. The first is that we know that if a child under 5 has got TB infection, by definition, they've been exposed to TB within their lifetime, and that implies recent transmission, as opposed to in older age groups where someone might have a positive result for TB infection, but we don't know if they were exposed many, many years ago or more recently. So looking at children gives us a better idea about contemporary epidemiology. And the second reason is this is an important potential group who might benefit from increased from treatment. So we know that children with latent TB have a high risk of progression to active TB disease. And so potentially this is a group that could benefit from therapeutic interventions targeting latent TB. But we also recognise that children may not tell the whole story of what's going on with TB transmission. And so for that reason, Mpatso, who's on the call, is also leading on a cohort of an additional study recruiting a cross-sectional sample of adolescents and adults aged 10 to 40, so that we also have that picture of what's going on across age groups. And during the study, we're using 2 different recruitment strategies. So the first is that we're performing sort of conventional cross-sectional random household sampling from neighbourhoods in Blantyre. And we've selected the neighbourhoods that are highlighted in lilac on this slide. So these are areas around Bangwe, Limbi and Ndurandi. And alongside that, we're also performing convenient sampling in these 3 primary health clinics or PHCs indicated here. So in Ndurandi, in Bangwe and in Limbi. And the household areas we're recruiting from approximately correspond to the catchment areas of these clinics. These 3 clinics see the highest number of TB cases in Blantyre, which is why we've chosen to focus on those 3 areas. And why look in clinics? Well, we hope that this might be a methodology that's useful for TB programs and that's sustainable. And we know that for something like this to be more sustainable and more widely used, it's extremely helpful if it's closely integrated within existing healthcare systems. So Malawi has a very well functioning primary healthcare network. We see a high uptake of primary care interventions such as vaccinations. And this means that recruiting in primary health clinics may be a sort of convenient, helpful way to target participants. And we were inspired by colleagues in the malaria group here in MLW who've used a similar approach for malaria surveillance in Chikwawa district, where they recruited children visiting clinics and sampled them for malaria parasitemia. And this approach was able to identify hotspots of high malaria transmission. We can do this because we have a validated app that we can use to capture participants' home coordinates. So essentially, this uses high-resolution satellite images combined with sort of tagged landmarks of the local area, which allows our field workers and nurses to work with participants to identify, to sort of find their house on the map and drop a pin. And this is a validated method that we've used. So the idea is that participants are coming from different areas to the clinic, but then we're able to identify their home location and analyse and perform spatial analysis based on that. But we recognise that convenient sampling has the potential for bias, and so alongside recruiting in health centres, we're also performing more conventional cross-sectional household sampling in order to allow us to compare these two methodologies. I won't dwell on the inclusion criteria, but essentially they're broad. We include children aged 1 to 5 who are attending clinics for routine appointments such as vaccinations or checkups, or who are accompanying other family members who are coming for care, for example, to antenatal care. And we exclude those in clinics who are presenting because they're unwell. Overall, our target sample size is 1,825 children aged 1 to 5, or 100 children with positive QFT plus results. And this is based on pretty limited background data from Malawi, but based on an ability to estimate a prevalence of QFT positivity of 5%. And just to say, we also have, as I've mentioned, a group of people aged 10 to 40 who are being recruited from communities. I'm not going to focus too much on them in this presentation because that's work that Impatso is leading on. So children come to either clinic or they're identified in the community survey. They have a baseline questionnaire and blood samples are taken for QFT+. And those who have a negative IGRA receive an SMS with their negative results and advice about TB symptoms. Those with a positive IGRA, we phone with the result and we ask them to attend a clinic. And if they don't attend, then we perform a home visit. And then just following through with these positive participants here, these are young children who we know are at high risk of active TB, who have a positive IGRA. So for them, we repeat a symptom screen. And if they're positive, they're referred to our paediatric TB clinic for further clinical assessment and investigation for possible active TB disease. And those who are negative are referred to the local TB clinic for TB preventive therapy, essentially following the local guidelines for under 5 TB household contacts. And they receive 6 months of isoniazid. And in addition to that, we also recommend that their household contacts receive contact tracing using Sputum Expert. And the final part of the methods, just to mention, is that within this, we're also nesting an evaluation of the CLIA-REACH QFT IGRA. So the QFT plus kind of conventional IGRA diagnostic is quite a resource-intensive process. And so the CLIA-REACH QFT is an alternative assay that's been produced by the manufacturers QIAGEN to try and simplify some of these processes. So it requires just a single 1 ml blood sample. It still needs overnight incubation, but then instead of having a lengthy ELISA process, it uses a single-use cartridge. So the sample is mixed with a buffer and then pipetted onto this e-stick, which is inserted into this self-contained battery-powered hub. And this then performs a nanoparticle lateral flow immunoassay, and it gives the results within 20 minutes, which is either negative, as you can see here, this is my blood, either negative, positive, or positive. And if it's positive, it also gives a time to positivity. Cool, so that's the background to the study. And I know some of you have heard that a lot, and for some of you that's new. So unless there's any burning questions on the methodology, I will move on and start to talk about results. Liz, as I say, I can't see the chat. So if there's any questions to address now, or shall I move on?
I'd say move on.
I would keep going, yeah. Yeah, especially as Titus has got five minutes. But that was great.
Okay.
So if yeah.
All right. So presenting some interim results, and as I say, this is work in progress still. So the first thing that we wanted to look at is it feasible to recruit in healthcare facilities and in communities, and can we perform surveillance using TB immunoreactivity as a methodology? So we started recruiting in October 2022. We've had several sort of difficulties and interruptions. We had quite a significant cholera outbreak, and then obviously tragically had a lot of damage from the cyclone earlier this year, and we've had a couple of protocol changes along the way. But we are on track, more or less, and aiming to conclude recruitment by the end of November 2023. And while we, I think, may not reach our overall sample size target, we're seeing a higher than expected rate of positivity, which means that we should reach our sample size target for number of positive participants. So currently we've recruited 812 participants under 5 for whom we have a valid GFT plus result, of which most are from the clinic, and then a smaller number from the community, where we started recruiting more recently. And I will skip over this for the interests of time, but just to say we're able to identify participants in clinics. The most common reason for participants being ineligible is that they live outside the catchment area. And the most common reason for participants declining consent is that often we're approaching a mother who's attending with a child, and often they feel quite strongly that they need to discuss with the husband or another caregiver before giving consent to participate. But as I say, I'll skip over this for the interest of time. So what I'm going to do now is sort of present a table 1 of the characteristics of the children under 5 who we've recruited so far. And I'm going to break these down by recruitment site, particularly because we're worried about whether or not we might be recruiting a more biased sample from clinics compared to what we're seeing in the community. So we've got clinic results on the left-hand side, community results here, and the sort of overall makeup of our population on the right-hand side. So the main difference really that we're seeing is that we recruit slightly older children from the community than from the clinic. So the median age of 3 as opposed to 2. And that really reflects that, I think, the fact that younger children are more likely to be firstly brought with their family members to the clinic, and secondly, more likely to be having things like vaccinations and under 5 follow-ups. The most common reason for attendance is they were going along with someone who was attending family planning. We also saw quite a number who are coming for sort of under 5 checkups and for weighing. And the remainder are sort of accompanying family members attending the clinic, relatively few coming for vaccinations. PMTCT is very successful in Malawi. So as we would expect, we're seeing very low rates of HIV positivity in children under 5. And these are no different between different groups. What we are seeing, interestingly, is quite a high rate of HIV positive mothers, and probably slightly higher than we would expect to see in sort of a general antenatal population. So in the clinic, 21% of children that we're recruiting are HIV exposed, so their mother is HIV positive, and a slightly smaller but still quite high number in the community. And this is not statistically significant, but it, I think, does just make us think a little bit whether we might be seeing a slightly higher rate of HIV exposure in our clinic population than we would expect to see otherwise. Rates of BCG vaccination are very high in all groups. Rates of previous TB treatment are very low in all groups, and relatively few really children their guardians report a household contact who's been treated for TB during the child's lifetime, so less than 1%, and similar numbers from the community, although I don't have those numbers just now. We also ask the guardians, to sort of report on how healthy their child is in general. And we see pretty similar kind of distribution of self-reported health amongst the clinic and community. So I think in general, it doesn't seem that we're recruiting a particularly sick bunch of kids from the clinic, which is what we're hoping for. Again, to sort of look into that question, we do a mid upper arm circumference on the kids, looking for any signs of malnutrition. And possibly, again, a slightly high rate of lower nutritional status in the clinic kids from the community. And quite a few kids are coming to the clinic for sort of checkups and weighing. So possibly slightly unbalanced populations that we're seeing here. And across the board, if you ask parents of children under 5 whether they've got a cough or any of a list of current symptoms, quite a lot of them will say yes. And that is the same in both the clinic and the community setting. So I think from this, what we're seeing is we're recruiting good numbers of children. We think that in general, they seem fairly well balanced. We think we're recruiting a reasonably well balanced, sort of representative-ish group of kids from the clinic. But we acknowledge that this is convenient sampling and there may be some biases there. And there may also be biases there that we're not measuring. So the next thing I'm going to talk about is the prevalence of IGRA positivity. And again, I'm going to focus on the under 5s, but just mention as well some results from the older age groups. And really the headline here is we're seeing a higher rate of IGRA positivity than we expected to see. And I would say the second headline is we're seeing a higher rate of indeterminates than we expected. So just focusing on this column first of all, which is the under 5s. So with a mean age of 2.5, we're seeing 9.6% with a positive QFT plus result, a further 10% with an indeterminate result, and around 80% negative. And then, as you would expect to see, as we go up the age groups over to the right-hand side, the prevalence of positivity increases. And this really just reflects the fact that people have had more years of cumulative exposure to tuberculosis. So we can use sort of ignoring, I'm going to set aside the indeterminates for now, although that might be something we can come back to in the discussion. But if we set aside the indeterminates, then we can calculate an ARTI, or an annual risk of TB infection, for each of these age groups. And looking at the under 5s, what this equates to is approximately a 4.6% annual risk of TB infection. So a 1 in 20 chance, 1 in 20 something chance that a child will become infected with TB per year, which is pretty high. And we can calculate this as we look through the older age groups. What I would just point out is that to do this, we're using the very naive formula, which assumes a constant ARTI and, really importantly, no reversion. And actually, we increasingly understand that as we move up through the age groups, these numbers are likely to increasingly be underestimates, because there's probably considerable reversion and other factors that are going on here. But certainly what we're seeing is on the young kids, it looks like an annual risk of TB infection in the order of 4.6%. And an obvious question is this higher in the clinics than in the community? Is this because we're recruiting a biased sample of participants in the clinics, and that's why we're seeing this higher level than expected? And the answer basically is no. So if anything, the prevalence of QFT positivity is a bit higher in kids that we've recruited from community rather than from the clinic. I think probably a lot of that is accounted for the fact that kids in the community are a bit older, and so they've just had more cumulative years of exposure. But certainly what we're not seeing is that it's a high rate of positivity in the clinic kids, which is driving this high rate of TB infection. I'll mention briefly the participants who we follow up who have a positive QFT plus. So we're very much sort of still in progress of tracing these participants and reviewing them in clinic. But so far we've seen 60 of them again, of whom 16 were symptomatic, and they get referred to the TB clinic. And so far we have 1 participant who's actually been diagnosed with active TB based on a positive stool expert. And we have 8 participants who've sort of completed their workup through the TB clinic, and others who are undergoing ongoing follow-up and tracing. Okay, so the third area of results that we wanted to talk about is about the diagnostic performance of the ChIR-H QFT compared to the QFT plus. And there's been sort of a handful of published diagnostic evaluations of this assay, and they've predominantly looked at TB cases.
Sorry, can I give you a 1 minute warning?
You can, but it would be a bit premature based on when I started presenting. But I will note your 1 minute warning. I've
just
probably got about 5 more minutes.
Yeah, yes, but I'm thinking that others will be more interested in the data you've presented and the spatial data than in the Kaya-reach. So possibly to skip section 3.
All right. I'm going to talk about it really briefly. The headlines are that it's really easy to use. We got good feedback from the lab team, but we saw really poor performance of the Kaya-reach compared to the QFT+. So looking in all age groups here, if we consider the QFT+ to be the gold standard, which is in itself a problematic thing, and we know there is no real sort of gold standard test for TB infection, we found a sensitivity of 61%, a specificity of 74%, and a sort of kappa agreement of 0.26. So this is in all age groups, and you can see here that let's say of people who had a positive QFT+, of 155 participants, only 96 of them had a positive Kaya-reach, and 59 had a negative Kaya-reach. And if we look at those who had a negative QFT+, 583 of those had a negative Kaya-reach, but 200 had a false positive Kaya-reach. And if we break this down by age group, the performance is even poorer in younger children, slightly better, but still not very good in adolescents and adults. Skip over this. Okay, and then the final thing that we wanted to look at was around the spatial distribution of QFT+ positivity. So we are interested in whether or not we can use surveillance methodologies like this as a way of guiding more targeted interventions. And there's good evidence from sort of modelling studies to suggest that targeted interventions may be very impactful, but it can be very challenging in practice to know where exactly to target those interventions, given what we know about the limitations of the data sources that are available. So, I mean, this is sort of what the raw data looks like on the left-hand side. So these are the areas in Blantyre that we're working in. Each one of these dots is an individual who we've recruited into the study, and this is specifically just looking at the under 5s again. The red dots are QFT negative, and the greeny dots are QFT positive. We're still obviously in the process of recruitment, but this is what our data is starting to look like in terms of being able to understand the distribution of QFT+ positivity. And obviously, you know, in some of these neighbourhoods, the numbers that we've recruited are still quite small, so the confidence intervals on a lot of this are wide. But at a very basic level, we can start to calculate an ARTI by neighbourhood. And what we see is, you know, really quite a high degree of variability. So in some neighbourhoods, our point estimate is near to 10%, whereas in others it's low and sort of well below 1%. So again, as I say, while the confidence intervals are wide, we are starting to, you know, we're starting to see what we expected to see, which is a degree of heterogeneity.
And just to mention where Indorandi is for those not used to seeing these maps.
This is Indorandi, this is Bangwe here, and then this is Limby coming in here. And then the next question is, well, does this just tell us the same thing as case notifications? Like, can we just use case notifications to get this same information without having to go to all this trouble? And essentially, it looks like they're giving us different information. So here on the left-hand side, we have case notification rate by neighbourhood, where the sort of brighter blues here are the areas with the highest case notifications. And this is the map that we've seen before, where the brighter areas are the areas with the highest risk of TB infection in young children. And what we're seeing is that the two maps essentially don't highlight the same areas. So, as I say, this is preliminary data, but one possible interpretation is that we have areas of high transmission that we're seeing, which are reflected in high rates of IGRA positivity in young children, but that those aren't necessarily reflected in high case notification rates, possibly because of a high rate of undiagnosed TB. And just showing that data, but in a slightly different form. So what we're looking at here is essentially the correlation of cluster level risk of TB infection in the under 5s compared to the case notification rates. And again, while the confidence intervals are very wide, I hope I can convince you that there's not very much correlation between the two. It doesn't seem that high case notification rates consistently correspond to high ARTI. All right, so in conclusion, what I've presented so far has hopefully shown that, we found that IGRA testing for surveillance using convenient sampling in healthcare settings appears to be feasible. And secondly, we found a high prevalence of IGRA positivity in children under 5, which does suggest high rates of ongoing TB transmission in Blantyre. Thirdly, we found that the ChIRH QFT was very easy to use, but unfortunately did not perform well enough to sort of fill this role in community-based surveillance. And finally, we found that IGRA positivity amongst young children shows spatial heterogeneity, which differs from that of TB cases. And the next steps really from our end are going to be to complete recruitment on this and obviously to complete some of the analysis on some of these areas and particularly diving a bit more into the spatial aspect. So just to finish with, I had an acknowledgement slide, but it doesn't seem to have come up. So just to acknowledge, firstly, the National TB Programme and the Blantyre District Health Office for the support that they've given to the project. Secondly, to mention my supervisors, so Peter, Liz and Emily, and also Mpatso, who's the co-PI on the Timasamala study, and all of the public health group at MLW, in particular Hannah and Bale, and the whole Timasamala team. And also really to thank all of you, because I think pretty much everyone who's on this call has given some input to the project at some stage, and I've been really grateful for all of that input. And so looking forward to opening things up for discussion now. Thank you very much.
Thank you so much, Hannah. Brilliant. Really, really great presentation under challenging circumstances and very good to see such interesting data. Before we sort of dive into the discussion, can I just very quickly ask, are people able to stay until 2? Is there anyone who's not able to stay until 2? And are people able to stay until 1:15? Is there anyone who's not able to stay until 1:15?
I'm not able to stay past the
Ryan
hour.
and Ted. Yeah. Okay. So in that case, are we going to give you 2 quick authorization to jump ahead of the NTP? So think of your questions. I do think we need to introduce colleagues from the National TB Programme now, but after that, let's quickly double down to Ryan and Ted for your thoughts before get to anyone else, if we can stay until 1:15.
Okay. We're okay. We will do it after they've done their questions. Thanks.
Yeah. Okay, that's great. Good. Okay. So Kazani, you'll do the introductions afterwards, or you?
Yes, please. Afterwards, I'd like to hear what they have to say.
Yeah. Okay, that's great. Good. So okay. So Ryan, Ted, and others, please feel free if you've got comments as soon as we hear thoughts there.
Yeah, so, Ryan, you go ahead first. You got your hand up.
Protocol,
I think
Ted.
yeah.
No, I just, I mean, it's really interesting data, very nice. I think it's really nice to see another way of showing how notifications are problematic. So it's really nice work. I have 3 questions. One is how the ARTI, even if it's an underestimation more likely than overestimation, that's really high, and compared to the case notification rate is really high. And given that you've done prevalence surveys in the area, the case notification rate overall isn't wildly off, in the sense that you can't, there isn't like 5 times more cases roaming around. How do you have any ideas what's happening? Like, do we just misunderstand TB in general? Like, what's happening? And more about the outcome, the mapping is only showing one color, and showing composite walls on a map is hard. There are some techniques apparently, I don't know that, but how narrow or wide are the composite walls, and what's your endpoint? Like, how narrow or wide are they going to be? Like plus minus 1% or something else? And that comes to the final question, with the question of what we're going to do with this. Like, how granular do you think we should need to get to really do something different than what we're doing now? Because this is cheaper than doing a prevalence survey, but it's not resource free. So how granular you need to get to do something useful? Thanks.
Yeah.
Thanks, Ryan. So, I guess one by one, yes, the ARTI is much higher than we were expecting to see. And I think that's, one of the things that we really wanted to get people's insight into. Obviously a lot of I think while it's high, it's not totally incompatible with some of the results that we see. Well, so there's not a lot of data from Malawi. So there was a national prevalence survey in 1994, but obviously that's a long time ago, and it didn't include blantyre. So we basically don't have any directly comparable data. And what we do have is predominantly from older age groups, so from 6 to 11s. And if you take into consideration that you think there might be a 20% annual reversion rate, let's say, then it certainly is possible that what we've been thinking of as the ARTI based on those results from predominantly older age groups is an underestimate. And so that looking at the younger age groups, this might reflect a sort of a true higher level than we've seen. I think that's possible. The sort of other things are, that there may just be a lot more TB circulating than we realised. One thing to mention is that these are kids who've lived most of their lives through COVID. So we don't know if there has been, if there's been a 20% delay in how everyone's been diagnosed over the last 2 or 3 years. That obviously could result in quite a significant increase in infection, although it doesn't seem completely credible. So I think the short answer is we've been bouncing around ideas and trying to think it through, but it definitely is much higher than we expected to see. And we are seeing kids who are, we have found one child who does have active TB disease. So we are sort of also getting a sense of whether or not this is a true signal that we're seeing, but very much a kind of active question.
Just a quick follow-up. That's okay. Just because, there's been, I don't know the names of the districts in Blantyre, so I might have misunderstood, but there's been lots of active case finding studies where whole swaths of the population have been screened.
Yeah.
And my understanding is that the rates have been plummeting that you're finding of the bacteriologically positive disease.
Yeah.
And how that relates to, and I don't know what level they are, but how that relates to background ARI in kids of like 4 or 5% seems hard to. It's not just the immunoreactivity that you're seeing; it's just the relationship of that to disease seems off compared to what we think we know. And I say think we know with purpose, obviously, because there's lots of stuff we think we know but isn't true. So it just seems having the disease background seems particularly challenging to match. So yeah, worth more thought and discussion.
Yeah, 100% agree. I think.
Yeah, so undiagnosed infectious TB was 0.2% in 2019 in those areas. And that top left, the dense in Durandi, has been particularly the focus of case finding interventions, both by us and by the National TB Programme. Should we quickly move on to Ted?
Sure. So first, Hannah and the whole Malawi team, this is super impressive, the sort of amount of progress made in a relatively short amount of time, even given all of the, especially given all of the challenges. So yeah, it's fascinating and really sort of eye-opening to see these, really high estimated levels of TB transmission in this youngest age group. So yeah, this is going to be of interest to the community. I'm, super interested in understanding some of your plans moving forward around trying to understand you pointed to some of the final results about the spatial heterogeneity in these estimated ARTIs, and I just wanted to hear a little bit more about your analytic plan related to, trying to understand what the potential sort of underlying associations of those high rates might be, how to potentially connect that with some of the things that you talked about with underdiagnosis, given the discrepancies with case notification rates, and one of the things that sort of running through those questions is trying to understand how you're thinking about, do you expect that there should be, like, even though you're calculating these sort of at the neighborhood level, do you expect that there should be some sort of spatial patterning of this, where you know, neighborhoods close to one another should share some of these effects, and how you're thinking about doing that analysis?
Yeah, thank you. So yes, obviously what I presented now is kind of very, very early spatial sort of first glance. And the plan is really to spend quite a lot of the next year doing all of those things and having a look at them in more detail. I think, as you said, I think an interesting question is how. So I mean, the plan is to use a Bayesian spatial framework to look at the distribution of TB, of MTB infection compared to so IGRA negative kids, and be looking at the risk factors. And obviously we know about risk factors at an individual level, we know about household level, and we do have quite good data on the sort of neighborhood level characteristics. So hoping to understand how much of the spatial distribution that we're seeing is explained by some of those factors, and whether there is kind of, you know, residual spatial correlation that might reflect that some of these are, I guess, sort of outbreaks or areas of active transmission. And I think, you know, as you've mentioned, you sort of alluded to, that one of the issues is there's, you know, I think it's hard to like get to the bottom of what the truth is. Like, there's not kind of a gold standard. What we'd like to see is a really great deep TB disease prevalence survey with more cases than 29 cases. You know, I think about 15 across our whole study area, that would allow us to really kind of understand what the true, you know, what the truth is. And I think the difficulty, you know, I think what we have is like one version of the truth and another version of the truth, and I think it is quite hard to know that. But what we can look at is whether or not, you know, what we've seen, for example, with our case notifications, is we know that they don't correlate well with things that we expect to be associated with TB. We know that they're higher in areas, you know, with fewer men, for example, and further from health, so nearer to healthcare facilities, etc. So I think one of the things to look at is whether the risk factors we know to be associated with TB burden do kind of come out with being associated with TB transmission risk. And it'd be interesting to see the sequencing. So yeah, I think that's the kind of the broad plan, is to spend a lot of time thinking about it, and it would be great to discuss it in more detail.
Yeah, super cool. Thank you.
And Pete.
Thanks. Oh, do I have to put my hand down, or maybe it'll go away by itself?
I think you have to put it down somehow, but don't.
I'll figure that out after.
Yeah.
That was that was really exciting and thought-provoking. I suppose one comment and then a few related questions. So the comment, I suppose, is that you know, I was thinking back to the QFT-based measurements of ARTI from treats, which were done differently and in different age groups, so older ages and serial, you know, measuring longitudinally. But they also, and also in communities, I suppose, with higher TB prevalence, but they also came up with extremely high ARTIs. So, you know, getting on towards 20% in some of the South African communities, and I think some of the.
And sorry, Pete, this is what age group?
It was 18 to 24.
Yeah.
Anyway, I mean, I continue to find that data confusing and need to think about it more, but just to point out that exists and has similarities, and maybe worth kind of talking to Kwame and co and figuring out what they've been thinking about. And then the three questions are kind of all to do with tests, and they go from, I suppose, the sensible through to the silly. So the sensible end of the spectrum, you mentioned like lots of indeterminates, and I guess you've looked at treating the indeterminates in different ways, and I wondered how sensitive estimates were to that. The kind of level 2 question is, I don't know how well understood it is what like dot count, whether dot count tells you anything beyond you know, yes, no, and whether you have those, and if so, whether you've thought about looking at dot count rather than dichotomized test results. And then at the most ridiculous end of the spectrum, not knowing anything about this higher reach test, is it measuring something different? Does this discrepancy, is there any way that is useful? I mean, does it tell you something else, or is it just a complete irritation?
Cool. Yep. Thank you. All great questions. I guess maybe on the Chi-Reach, the first thing I would say is that the Chi-Reach actually gives us even more positives than the QFT plus. So it's definitely not the solution to our higher than expected levels of positivity. And we don't
It was
know,
basically a manufacturing problem, wasn't it? I mean, you know, realistically,
well,
so there was, it went to another manufacturer. As soon as we drew attention, they pulled it and said that there was problems with the manufacturer. So I think this is a COVID supply chain issue, honestly. You know, I mean, let's be.
I'm not sure we totally know that, but yeah, I mean, I think we're not quite clear what's going on with the Chi-Reach. Is the short answer. And we have had quite a lot of communications with QIAGEN, and they've been out to visit to have a look at what we're doing, etc.
Yeah.
I think one possibility is that might have contributed. And we've had a bit of a look, and I'm having an ongoing look to see if it is telling us something helpful, but I'm not sure it is, unfortunately. Yeah. But maybe there's something buried in there, and the company
doesn't think so, though, because they did pull the manufacturer. So that's, to me, it's
this is less diplomatic than me. And then I think so. Yeah. And with the indeterminates. So we were seeing a higher level of indeterminates than we expected. And I think probably some of that was accounted for by issues in the laboratory. So we had, for example, some samples that were delayed in getting to the lab, and that probably weren't processed completely correctly, and that will end up giving you an indeterminate result. But I think some of them, I think a lot of them are sort of true indeterminates. And yes, we had a look at sort of dealing with them in either direction and seeing how that, what that kind of resulted out at, and it doesn't really make a huge amount of difference overall. The third question was, yes, so I think definitely one of the things that we want to do is, rather than looking at these as kind of binary data, is to look at the IGRA results as a sort of more continuous variable. And in particular, you know, there's various different cutoffs that have been proposed for QFT plus, as sort of defining what should be positive or what should be negative. And all of those cutoffs really have been, you know, designed to be for a QFT plus to be used in a context where you either have really sort of exposed people like household contacts or people with a kind of known risk versus controls, and that's, you know, that's what's kind of been used as the way of working out what should be a positive and what should be a negative IGRA. And obviously the population that we're dealing with here is different from that. It's a sort of community-based population that includes the full spectrum of people who've been exposed to a bit of TB on the bus, to people who've had a sort of true intense exposure and have kind of genuine infection, to people who, you know, who haven't. And so I think, you know, I think it's not a given that the same cutoffs that we use for defining IGRA positivity in the one situation is the same that should be used in a population situation. So yes, one of the things that we're doing is definitely looking at them continuously rather than just as a binary.
And just to chip in there, so the dot count is the ELISpot equivalent, isn't it? So you'd be doing time to positivity or the overall. Anyway, I mean, as you said, there's a variety. And sorry, the second thing, beg your pardon, the second issue that I was just going to pull up there is just that that this age group, you know, we haven't been able to do TB infection in young children before. So because of the problems with skin tests in kids who've had a BCG vaccine. So we really don't know that much about the sort of under 18 months, and they may well behave differently, you know, in terms of how they manifest TB exposure. Can I ask Pete? Can I just say, just as we're 2 minutes away from our initial from the 2 o'clock time, the 3 o'clock time in Malawi, can we move to NTP instead? Is that okay? Kazani, any comments? And well, first of all, thanks so much for joining, and apologies that it was even more difficult for you. Go ahead.
No worries, Professor. I believe before I ask my question, I'm joined by a team of people, Dr. Munyinkulu, Dr. Moyo, Mr. Chimatiro. Those are the ones I can see on my screen. If I've missed any, my apologies. For me, personally, I didn't hear how, who's being, the population, apart from the children part, I've noticed 0 to 5, and then I think young adults, and then adults, it seems have all been tested.
Yeah.
I don't know how they were selected, so on and so forth, but I am interested in a question on what does this say about our active case finding, our active case finding efforts, considering they've been done with, for the most part, especially in that area, with what is the most sensitive tests available close to the patient, gene expert, ETC. So given all of this, given what you found, what does it mean in the context that notifications are going down, but you're finding this high infection rate? What's going on? I thought Ryan, Dr. Huben would say something when he started the subject. I'm aware of papers on subclinical TB, and I think he's part of that whole area.
Yeah.
So I wanted to know, how does this all link up? That's my question. Thank you.
So, and just very quickly, so before passing on to Hannah, as you again, apologies if you've had difficulties accessing. We do have a recording. I think the so the focus here is on the under 5s, and we were particularly interested in that group because if you do find an infection, then they're eligible for treatment. So again, I think as well as targeting ACF, this would be a great way for Malawi to scale up your treatment of latent TB infection, if that's a path you want to do, and if you're struggling to find household contacts. The last thing I heard on the household, on the preventive therapy targets, was that the global target is at 3%, so only 3% of the preventive therapy that was promised has been delivered. So I'm assuming that there probably will be a sort of focus on that. So just that's one possible utility, Kazani, that you might not have considered, but I certainly would be interested in it. And the under 5s, obviously you're talking about recent infection. In the under 5s, I think lots of people's work, including the work that Pete Dodd alluded to, retreats, which was in Zambia and South Africa. You know, what we think we understand about TB epidemiology based on tuberculin skin tests that you can't do in young kids. So based on those primary school surveys, just doesn't really fit with what we're seeing, certainly with these IGRA's tests. So they're tests for TB infection. They're more like a tuberculin skin test infection, a tuberculin skin test, than they are a gene expert. But I would certainly think that we would be able to target, is particularly if the program's willing to follow up and investigate high, areas where we think we're getting high infection, which again, Ryan made the valid point that ideally needs more numbers. So if you like, if we think of Hannah as a pilot, what would we next think about for a demonstration project? What would be the aims there at a slightly larger scale? But definitely, I think it's something, although, it's not trivial, but I think it's definitely doable, especially in Blantyre and Lilongwe, where we have 2 research institutes taking part in TB vaccine trials. So that means that, this test is going to be used for screening entry into those TB vaccine trials in both Lilongwe and Blantyre. So I do think it's an unusual opportunity. Anyway, that's my sales pitch. I hope I've answered your question. So I agree with you. It is odd to see that high infection. I'd be liking to see it repeated on you know, getting just a clearer definition about exactly which kids we're going to offer. The national programme would like to offer a test to from the under 5 vaccine clinics or weighing clinics, and how that could be used to better target case finding, I think, and to deliver more preventive therapy, and preferably validate that the use of preventive therapy in kids identified in this way, which again is new. It's all very new, Kazani. This is like global first in Malawi. We'd love you to be as interested in it as we are. Anyway, back to Hannah. Sorry.
No, I think really just echoing what Liz has said. I think, you know, we need to work out how this corresponds to the burden of active TB disease, but we do know that, you know, one of the advantages of this is that we know that there are groups that we find it hard to reach with TB active case finding, and there are always going to be people who are going to miss in our TB case finding studies. And, you know, potentially an advantage of looking in a cross-sectional way at children is that they can act as a sort of sentinel of where there is ongoing transmission, even if we're struggling to find the index cases themselves. Thank you.
And it does fit quite nicely, Peter McPherson's, your original analysis of case notification, suggesting that there was under ascertainment in the peri-urban parts of Blantyre, where you've got, you know, not such well-developed clinics. People are quite transitory. There's a lot of we know there's a lot of new HIV infection there. So the patterns at hand. That's why I was interested to see, you know, that it's that peripheral, the peri-urban area, as Peter found. I don't know if you want to comment on that as well, Peter.
Yeah, no, thanks. Yeah, just to say, I think there's a lot we don't know here, and we're getting imperfect signals from lots of different sources. But I do think the data that Hannah and Impazzo have gathered here are probably a lot more robust than many of the other sources that we have, and I'm really excited to see the end of the analysis that will hopefully tell us more than we have previously known about what's actually going on in the last few years in Blantyre and in Malawi. So yeah, well done. Yeah.
And Hannah, just quickly, how many positive cases do you have so far?
78.
From 800. Yeah, so 78 from 865. So again, Kazani, if you compare that to a prevalence survey, you know, it's really just the number needed to screen is so much less, but you can quite easily get, you know, the kind of numbers that you need to give you spatial resolution. Any other comments from the program? And Pete, you've got your hand up. Pete Dodd, you've got your hand up. I don't know if that's an old one or a new one or both.
It's a new hand, yes. Yeah. So one question and one comment. The comment was just thinking about, you know, what Ryan observed about, you know, the kind of, I suppose, the historical downward trend, and yet the also downward trend by age in average ARTI experienced, which kind of runs contrary to what you'd expect. I guess, I mean, I'm probably not completely on top of what is known about the likely dynamics of reversion over time, and potentially with respect to age, because that certainly provides a potential explanation for that, doesn't it? That if it takes a while for you to revert and then you have partial protection, then that could quite easily, with the right degrees of those things, lead to the pattern that you see there.
Yeah.
And the question, yeah, which I think is,
I was just also chipping. I mean, kids may have, you know, they may need a lot less exposure to get infected in the first place. You know, their lungs are tiny. They haven't got very effective clearance. You know, so if you think about it, for an MTB, you know, from a bacillus, you've got a way less way to travel to hit that alveolar in a 1-year-old than you do in a 10-year-old. So I would also be thinking that there may well be, individuals' age-dependent susceptibility to infection simply from that kind of mechanical. Plus, we know that there's also difference, quite substantial immune differences at the age of 1, but merely the mechanics, I would say, would put infants at higher risk. So I would go ahead.
On the reversion front, so I put some of these numbers into it. So Alvaro and Ryan's kind of recent paper looking at reversion, and we know the reversion is highest in the younger age groups, so highest in the sort of 0 to 5s, and can be as high as 20% per year. And actually, if you do project a sort of hypothetical 5% ARTI that's constant across life, but with that sort of reversion rate going through, you do end up with numbers that are not that dissimilar to this. So I sort of think that that's probably the reason that we're seeing this, and I think what Alvaro showed really nicely is the reversion does have a really significant impact, particularly as you go up through the age groups and you essentially kind of plateau out. And so I think it's interesting what you were saying, Pete, about treats where they're looking more directly, where they're looking at people who are actually converting, also studies where they're looking every year and seeing this really, really high risk of infection. Obviously, what you're doing then is isolating what's actually happened in that last year rather than extrapolating what might have gone on over in the last years. And so I think that's why, to me, potentially a force of infection that is actually this high doesn't seem inconceivable and doesn't seem incompatible with the actual data that we're seeing in these kids and across the other age groups. But obviously lots more to sort of do formally to look at that.
And just sorry, Hannah, go ahead, Pete.
No, just to wedge in my comment. Or was it the question? I think maybe it's the question. They were both somewhere in between. It was about, I suppose, going forwards, and probably you don't have the numbers in this, but if you do end up, going wider and revisiting some of these places, I think capturing the stability of these results over time is really important to get of what it means.
Yeah. Can I just also mention just deaths? I mean, some of that, as well as reversion, there's going to be deaths from undiagnosed TB in that young age group. We know, but it's very hard to diagnose TB at that age group.
Yeah, that's true. And Pete, when you say stability, do you mean stability within individuals or stability at a?
I meant really at population was what I was thinking of.
Geographical. Yeah.
Great. Yeah.
Yeah, my point was going to be exactly Pete's. We need some repeated surveys over time and seeing what's happened, and in other more settings as well, I think, to kind of validate this. But yeah, and you do have I think a small number of individuals who you've got repeat blood samples on, so you will be able to look a little bit at reversions, but I don't think we've got large numbers in this data set.
Yeah. And just quickly, Tisungani. Go ahead. Tisungani, you're yeah, go ahead.
Thank you, Prof. Thank you, Prof, for recognizing me. I just have a question. I noticed in the presentation there was a talk about the annual risk of infection, and the estimated annual risk of infection, I think, is around 1 in 20.
Yeah.
I just wanted to find out if we could also use this in projecting the total number of cases that you might end up getting in a year. I'm asking this from a policy as well as from a planning perspective as a program. We might need also to have these figures and be able to use them in projecting. So I just wanted to find out if it's feasible and if we can use the figures that are being generated. Thank you. Over.
Yeah. Can I take that, Hannah? Is that just? I mean, just quickly, I would say that is absolutely possible, but it's not calibrated. It would need a separate sort of calibration. So you're talking about the old methods that were worked out by Stiblo, and used for so many years, and those can definitely be replaced with this type of approach. But we know that the annual risk of infection that you estimate when you're doing those tuberculin surveys is a very different measure. So, you know, the truth is somewhere here. You're getting one answer when you do a skin test infection survey in primary school children, and that's the one that Stiblo, that's the only one he had available. And this new one is telling us something different. So we can't just use the same formula as we did before. But so this is an annual risk of TB infection estimate, but it's not the equivalent of a primary school tuberculin skin test estimate. So I do think, and this is what Hannah's paper with Ryan was previously. I do think that we should be making use of these tests again to help programs estimate over and under notification and focus and for targeting. I think we can definitely do that. And particularly with this being young children who themselves benefit from being screened for infection and from preventive therapy, and children who are attending primary clinics not in primary schools that are so difficult to get hold of. I think it definitely could become the sort of bedrock of TB programs going forward in the same way that it used to be. But we need to repeat all those numbers and try to understand how you can do those simple rule of thumb using this approach. Any other comments from others?
No, I agree. I mean, I think as you know, what we're really interested in ultimately is the TB disease burden. That's what's killing people ultimately. And this is another tool that we can use to try and give us an indication about what is going on. But I think, as Liz has said, you know, unfortunately, the relationship between this and TB cases is not sort of linear or straightforward, and there are lots of other things that are going to impact it, like, you know, how much HIV there is in the population, etc., that will affect how many cases you end up with based on what your risk of TB infection is in the first place. So I completely agree from a program perspective. That's the holy grail, and that's what we actually want to get at. But the question is going to be, how can we use this data, which potentially is more readily available, to help us to understand as much as possible about what's going on with TB disease.
I remember Tony Harris used to love his ARTI estimates. I'm just laughing. So folks here on the call will have made that, you know, they will have sort of done those calculations personally. No, good. Okay, we're now 18 minutes past. So should we say close in 2 minutes? Anyone, any objection to that? So we've got 2 minutes for any last comments. But Kazani and others on the call from the national program, can we take it that you're keen to explore how to take this forward?
Yes.
Great. Good. Any last comments? Any last points from anyone? So thank you to everyone then for sparing the time. Again, delivering interest and wise comments and enthusiasm in challenging circumstances for the connection. The recording is with Peter. So Peter, you'll be able to let anyone who wants to access the recording see the recording. And Hannah's in Malawi in any case, so if anyone wants to catch up with Hannah, that in principle should be straightforward. And just as another aside, Kazani, this is using the very same EPAL that we're already working to integrate into the World Bank TB electronic database. So again, hopefully lots of reasons to be talking about that anyway. Yeah, so thank you to everyone. We'll have a report of the report from the meeting as well as the recording, and Hannah, I'm sure, can share slides if that's also helpful. Yeah. Anything I've forgotten to say, other than to wish everyone a very good rest of the day, and thank you again.
Thanks, all. Nice to see you.
Yeah. Okay. Bye.